very warm and heartfelt welcome on behalf of Patients Today and Mamma Mia to our detailed Congress coverage from ESMO. ESMO stands for the European Society of Medical Oncology, and this important Congress took place this year in Berlin with nearly 40,000 participants attending. First, we will report, that's Professor Kümmel and myself, on the topic of early breast cancer, specifically hormone receptor positive cases. Welcome, Sherko. It's great to have you with us again, and maybe you'd like to briefly introduce yourself.
Alexandra, thank you very much for the invitation. I'm always happy to be here again. I was at ESMO. I'm basically an ESMO member and part of the breast faculty there. So I was especially curious in my role here now, when I'm not at ESMO, I head the Interdisciplinary Breast Cancer Center at the Essen Clinics as part of the Women's Cancer Center.
So let's take a moment and dive right in together. At this point, I would like to invite you, Sherko, to share your thoughts and insights with us. Please, the stage is yours.
So this year, once again, as has been the case in recent years, ESMO featured a real fireworks display of new data with symposia that were presented as presidential lectures and so on. And together with Alexandra von Korff, together with the team, we selected what we would, let's say, report to you about the situation. And given the limited time, we only selected as much as we could. Things that are truly relevant for everyday clinical practice, and that's quite a lot. So with that, let's get started and see what's out there. What either confirms our current treatment algorithm or our decisions, or what changes them. And there was plenty for both. So stay tuned, there's a lot coming up now. So this is the disclaimer. These are my disclosures. And we'll start right away with the first study, which was actually presented on the very first day, I would say on Friday, by Stevens Johnson. He is, so to speak, the responsible principal investigator, as it's called, for the monarchE study. That means we are dealing here with early, that is, adjuvant, curable breast cancer, specifically when it is hormone receptor positive. This means that the estrogen and/or progesterone receptor status on the tumor cells is positive. What was investigated here was, for example, if patients had lymph node involvement and additional risk factors. Then they looked at this and examined what happens if you use only anti-hormone therapy, which is well known, such as aromatase inhibitors, or if you add the CDK4/6 inhibitor, abemaciclib, to this therapy. So in other words, for whom is this study relevant in all of this? Again, hormone receptor positive patients who do not overexpress HER2/NRU at the same time. That's how we summarize it today in all of this. The risk of recurrence is somewhat higher if several lymph nodes are affected, meaning at least 4 or more, or if 1 to 3 lymph nodes are affected, but there are additional risk factors, such as GE3, the grading, or a tumor size greater than 5 centimeters. And this is an adjuvant application. That means we're talking about the period when you take the medication in addition to the anti-hormone therapy after the operation. And abemaciclib is taken for an additional 2 years during this time. So now let's move on to the study design in all of this. That means we now have, and this is the most important point, without going into more detail, a study that has changed everyday clinical practice. Since 2022, we have had approval for abemaciclib in all of this because we already received the first data showing that in terms of survival, what is called disease-free survival, it was better than if patients did not take it. And now, once again...
So now, would you like to briefly explain what exactly a CDK4/6 inhibitor is? So in this case, abemaciclib.
So the CDK4/6 inhibitors, and this is perhaps very important in all of this. So in the past, let's say in biology class, we used to imagine the cell cycle like this. Of course, it doesn't actually exist, this circular one. And if we, so to speak, followed our biology teachers from the M phase, G phase, S phase, and so on, then for the cell to replicate, that is, to divide and be active, this circular schematically represented cell cycle is used. And at these different points, various enzymes are involved, so to speak, which accompany the process and ensure that it transitions into the next phase. And several enzymes are, for example, these CDK kinases, to make it a bit more complicated. And it has been found that if you inhibit 4 and 6, these are numbered, then this can additionally cause the cell not to remain in this active mode, but rather to fall into a kind of resting state. This means, for example, that it becomes even more susceptible to, let's say, anti-hormone therapy or also to immune cells in the body and so on. That's more or less the hypothesis behind it. If someone now says, I recently heard that there are also treatments against CDK2 and CDK7, yes, of course, the journey continues. Today we're looking at what the so-called CDK4 and 6 inhibitors have essentially brought to the table, and the fact that we can also present the data is shown in the sentence below. On average, 6.3 years of longer follow-up time. Yes, in all of this. So once again, it's what we call an escalation because we already have the classic standardized anti-hormone therapy, for example, in younger patients. Tamoxifen plus or minus this so-called ovarian suppression, yes, the suppression of ovarian function with GnRH analogs like goserelin or enantone or trenantone if you do it every 3 months with tamoxifen. If you use aromatase inhibitors in premenopausal women, you should suppress ovarian function monthly. Here with, so to speak, enantone goserelin. In postmenopause, the combination is usually with aromatase inhibitors. We know the 3, anastrozole, letrozole, or exemestane. So, as a brief overview again, what is the standard therapy and what is the escalation? That means in addition to the standard therapy, patients were given abemaciclib for 2 years, or in the control group, it was not given. So, just like in the standard approach. And from this, we can already see, if you were treated in such a study, which by the way started over 8 years ago, if you look at it, back then already half of the patients received a new medication. And today we can say for sure that it definitely improved survival. Outside of the study, you would not have received it at all.
Yes, that's another good reason to participate in studies.
Once again, my conclusion, studies create life in all of this. If we look at it, of course, the most important endpoint in cancer research is overall survival. That means if I look at several thousand patients, did more patients survive in the end, yes or no, in the whole group? And this was now presented at the ESMO in Berlin. What do the overall results look like? The reduced risk of death was almost 16% better, meaning over 6.5% more patients without relapse. And we ourselves, and it has to be said, we are not yet at the end of this journey because even for patients who unfortunately have developed metastases at some point, fortunately, with all the strategies we have available today, they are not left without good care at that moment, but rather they can be well treated and are still living. This means that we will see that this reduced mortality risk, which I showed earlier, will probably continue to improve over the years as a whole.
That's really encouraging.
So let's take a look at that. Here we have now talked about the reduced mortality risk. If we look at the recurrence rate alone, we see approximately this percentage among these patients overall. So that's about 30% less when expressed as a relative risk overall. If you look at the curves again in absolute numbers, you might think that's nothing overall. Why is it that in the end you can only achieve something with very effective medications? Because of course, even without this therapy, many patients, ideally that's the goal, still survive in the whole situation. Yes, in the whole context. And that's why I'm showing this again here, and I think this is the most important graphic for us. Here you can see, so to speak, metastases. Patients, that is, patients with distant metastases in the lungs, liver, or bones, to name the typical sites. And if you look here, when you add abemaciclib, it's significantly less. Development of metastases, that is the crucial point. This means that with 2 years of therapy, even if you look at the patients 6, 7, or 8 years later, we can additionally prevent patients from experiencing a recurrence. So, in other words, what is the conclusion? The first study, well, we actually have 2 that have been introduced as standard therapy. These are abemaciclib and ribociclib in this context. And abemaciclib is now the first study where there is an overall survival benefit, because this study has been observed for a bit longer, so it's a bit older in this context. The survival benefit has been confirmed. What does this mean for us, for our strategy? It means that really, every patient who is eligible for this should not be overlooked anymore. We've already been doing that. With us, of course, patients have already participated in the study. But even outside of a study, when the first approval came for abemaciclib at the end of 2022 and for ribociclib, also for a broader patient group at the end of 2024, these medications really should be mentioned, discussed, and offered to patients if they are eligible. If you look at it that way, this is my conclusion for clinical practice. It doesn't change our daily routine, but it does reinforce that the strategy we started a few years ago was indeed the right one.
It's actually pretty amazing, honestly. When I really think about it, if you go back again, you say, this definitely gives me this advantage. That's great. We should do that. But at the same time, you say it actually doesn't really change our standard in any significant way. Did I misunderstand that? So shouldn't that become the new standard then?
Is it correct? Well, for us in the clinic, hardly any patient who has needed this therapy since 2022 has been overlooked, I would say.
So then I understood correctly. You're already doing that, so nothing changes.
We've already been doing this, so to speak, and now I tell everyone who has still hesitated and said, well, I'll wait and see if there's an overall survival benefit. We didn't hesitate even with the first data. So as soon as we saw for the first time that this led to fewer patients developing metastases, it was already clear to us that we would introduce it as standard practice after approval.
Those are truly fantastic results. Can you tell me a bit about the possible side effects and the quality of life in your experience with this additional treatment?
Well, that's why I mentioned it earlier.
Yes.
We're actually coming from an escalation approach. Once again, this is a very important data situation. If we look at it, we administer something for 2 years, and the curves keep diverging more and more at the end. This means the first important point is, if you add something for 2 years at the beginning, you cure additional patients overall. What do you trade off for that in de-escalation? Of course, these medications have side effects. The abemaciclib it may cause gastrointestinal problems, which can make it worse. It may cause diarrhea. One must counteract this generously with Imodium, our travel medicine. Better sooner than later, perhaps even prophylactically in some cases. Meanwhile, other studies have been conducted where we started with a slightly lower dose. Start with a lower dose for the first few weeks. 150 milligrams twice a day is the standard. Now we start with about 100 in the whole process. In this situation, we also see that the rate at which patients say, oh God, even if I know this gives me an advantage, I won't continue, decreases. So you have many more patients who actually tolerate it well.
I think we discussed that study at ASCO.
Other side effects. This was the trade study exactly, which we discussed at ASCO.
Exactly. If anyone wants to look it up again, you can also simply find it with us.
So anyone who, that's right, wants to look it up again can focus on that and review it and say, aha, we haven't even brought that up again today because that's just part of our everyday therapy practice. That means if you administer it for 2 years, you lose absolutely nothing by titrating it more slowly during the first 4 weeks. In terms of effectiveness, I think you're right. That's something really important.
Exactly. And that way you stick with it instead of when the big hammer comes down and you say, oh God, I can't take this.
Exactly. If you then have 10% more patients who stick with it, you can calculate today how many more we can help survive. So if we were to do the math now.
Yes, fantastic. Also very good that you mentioned again that, of course, if there are any side effects, you should always say something right away because there are options. You don't have to just endure it, but always report immediately if anything comes up. Fantastic.
Yes, but you also have more frequent doctor's visits because, of course, you do blood count checks more often. So we look at, for example, the white blood cells, which can sometimes decrease. It can happen sometimes, although I have to say for me, that's not really a problem. Sometimes there can be a bit of hair loss, but I don't have a single patient who, let's say, had hair loss to the extent of needing a wig throughout all of this. So that's one aspect. You talk about it, you explain it. Of course, for me, good care means informing as much as possible and also taking preventive measures. So slow dose escalation, maybe even using Imodium very early on and so on, so that the symptoms either don't appear at all or are at least less severe.
Yes, it's good that you mention again that there are actually several visits to the clinic, which is important to keep in mind, or to the breast center or to the doctor, because that's also something that restricts your life a bit. I say, okay, so I have to show up there every week. How much more often do I have to go to the doctor then?
Yes, at the beginning, let's say once the first phase is done, where you might come in every 14 days for checkups, then it becomes monthly, and after that, every 3 months for the 2 years. Yes, but usually it's done in breast centers because, of course, the medications are quite expensive, require blood tests and so on to monitor things. We hardly have any patients who say they won't come because of that, especially when you have a medication that also helps to push back the metastases.
Yes, great. Yes, thank you very much. Then let's take a look at the next study.
Yes, the next point is, again, the question that often comes up. Since many people talk about Ki-67, do I need chemotherapy or not? And if it's low, does that mean I don't need chemotherapy? Or maybe even that I don't need this CDK4/6 inhibitor at all in the whole process? Because very often we doctors say that if the Ki-67, for example, drops or is low, that's not necessarily an indication for chemotherapy. So again, it's the same patient group, the same therapy we've been discussing for a while now, abemaciclib in addition to antihormonal therapy in this context. And here they looked at the same study with these patients and specifically examined the Ki-67. So what about the patients who had either a low or a high value in this situation? We all know that Ki-67 is a prognostic factor, which we also use, for example, to make decisions for or against chemotherapy. So the question was, can we use it to determine the effectiveness of abemaciclib? And I would say, if you look at it, these bars, which are now almost identical, it means no. In short, that's the concise summary. That means even if the Ki-67 is at 10% or at 30%, the effectiveness of abemaciclib was independent of the Ki-67 value. And that's clear to us as well. Sometimes it's not entirely clear to everyone yet, because they still treat it like chemotherapy, but it isn't chemotherapy. It also doesn't work like chemotherapy. And that's why it's effective in a different way, whether the Ki-67 is low or high. Because it's simply not chemotherapy. And I think sometimes that still needs to sink in a bit, so to speak, into people's mindset. And then you'll know that you can't base your decision on that. Here's another table, for example, and you can see, if you look at the middle, a hazard ratio HR, what is that? So, in all of this, everything less than 1 is considered significant, so to speak. And then you can see, for example, if it says 0.65, that means it's 35% better. So the difference from 0.65 to 1.0. If it says 0.66, it's 34% better. If you look at that and then look all the way to the left again and say, okay, was the Ki-67 high, was it low, whatever, with or without chemotherapy, we see everywhere, and this is important for us, the same hazard ratio. That means the effect of the therapy was the same in all the groups that were examined. What does that mean? It means I can't say, in other words, I won't give abemaciclib because your Ki-67 is only 10 or 15%. With 2 positive lymph nodes and grade 3, or the tumor was large, or you have 4 affected lymph nodes and I say, well, the Ki-67 is only 15%. We can't say that it's not effective. And these are also very important data that in the end are crucial for the therapists who have to think about this intensively again, that we to implement this in everyday practice, so to speak, and say, aha, I can't treat it like chemotherapy and say you get it or you don't, but rather it's independent of the Ki-67, so to speak. And here again, now you've seen the curves, now you have the tables with the individual values, and now, since we've gotten used to seeing the curves, how do you actually interpret such a curve? So here, the red ones form a pair and the blue ones form a pair. That means if the Ki-67 was high in the red group, then the dark red line shows that abemaciclib improved the outcome. If the Ki-67 was low, the light blue line, then abemaciclib, the dark blue line, also showed improvement there. So once again shown graphically here, it's of course prognostically significant, meaning a high Ki-67 is not quite as favorable in terms of prognosis. But we can see that the effect of abemaciclib is present regardless of the Ki-67 value. That is, so to speak, the most important message from this study as well. These data have also been consistently presented and analyzed now at ESMO.
Yes, and especially looking back at the monarchE study, there's another argument to say, okay, it really doesn't matter whether my tumor is growing quickly or slowly. It's always, always, always a good solution. So also in conversations with patients, to say it once again, if you don't actually do that, then it's basically being served to you on a silver platter, just waiting for you to take it. Or am I forgetting something?
No, that's correct. I agree with you. Most importantly, remember you can stop treatment if needed. When patients say, now I have this or that, I say I would start first. And if you then decide for this side effect or whatever the reason is and the effect I've seen, that's not enough for me to continue. But when I look at these data, there is no medical reason not to recommend it.
Great, that's fantastic. I really have no questions about that, nothing to add. I think it really speaks for itself. Then we can move straight on to the next study.
So then we're back to hormone-dependent breast cancer, so to speak. And now comes the next, I've already hinted at it, the next complicated name, ribociclib. I can only say to everyone, if you're all thinking ribociclib sounds difficult, but just ciclib, for us in the new therapeutic landscape, these are actually simple terms. Honestly, whoever keeps coming up with these names, it's terrible even for doctors.
And you just explained it so nicely. A CDK4/6 blocker or inhibitor, and that's basically the same family if you would like to say so.
That's the same family overall, but whoever comes up with these names in the future is just going to get worse and worse.
Yes, that's really true. That's
Well,
why I always really appreciate it when these abbreviations are used. That way you don't have to say those
exactly.
endlessly long, complicated words. Definitely.
That's true, so to speak. So now let's take a look at how things stand with ribociclib in all of this. Here it's the same again, the affected patients, and here there's a very important difference. There are also, back then, in the monarchE study, which was the first study, they didn't dare to include lymph node negative patients, meaning those whose axillary lymph nodes were not affected by tumor cells because it was unclear whether they would also benefit. Today, we know for sure that if you have a certain risk profile, you will benefit from it. So a certain tumor size, Chi67, as a prognostic factor should simply be included in the assessment. Or even with one you can remember, ribociclib, whatever. If the lymph node status is positive from the axillary lymph nodes, then there is an indication for it. There's no need to stratify any further. Even those with 1 to 3 lymph nodes who do not receive abemaciclib should at least have abemaciclib recommended as a treatment. And this is the study, the so-called NATALEE study in this context. Again, several thousand patients were studied. Ribociclib, another CDK inhibitor. And now the differences. Here the therapy is given for 3 years. Not 2, as with abemaciclib, but 3 years. And the therapy algorithm is also 3 weeks per month, 3 weeks of therapy, not morning and evening, but at one time of day and then 1 week off. So it's a bit different. But all of this will, of course, be thoroughly explained by the therapists.
But I think that's actually a really important factor to consider when deciding what this truly means for my life, what it actually means for my daily life and my quality of life.
Yes, and in this context, we have an overlap between both, so from 4 lymph nodes in both cases, or 1 to 3 with risk factors. But we also have a patient population where we say they actually need it. There is only an entitlement to ribociclib here, because only in the NATALEE study was this patient population examined. So lymph node negative with risk factors and so on. So studies, as always, the invasive disease-free survival, called IDFS, invasive disease-free survival, is essentially the key factor in all of this, the way you look at it. Here are the individual hazard ratios, and you can see again in all the endpoints related to survival, not overall survival yet, at this point, you can see an improvement. So the class of CDK4/6 inhibitors with the representatives ribociclib and abemaciclib when indicated. Then they essentially provide additional survival benefit. But abemaciclib already shows an overall survival benefit because I would say the study had a longer follow-up period. NATALEE, a study that started a bit later, but with a broader patient population, which is also reflected in its practical application. Here, so to speak, are the differences that can be observed. And here you can also see, because it was always said, does a lymph node negative patient where there are no tumor cells really need this therapy? The answer is the effect, the difference achieved is just as great as in lymph node positive patients. So the risk and the classification of the patient for whom it is recommended are decisive, not the lymph node status. An important message that we've essentially received here again, and this is also significant. Here, we're now looking at a follow-up period not of 7 years for the whole thing, but of 5 years. Overall survival, why do we already see a difference here? That will still take some time. You can see this because, for example, even patients who develop metastases in the 2nd or 3rd year now have a much longer average survival than they did in the past. So the effect will only become apparent much later as well. But even here, we can already see the separation of the curves. And in the coming years, we will certainly see the curves diverge further, just as we did in the abemaciclib study. Once again, and this is always the most important table for me, even if at first glance it's not so easy to analyze, it's about the question, how many metastases, meaning distant metastases like lung, liver, or bone, am I actually preventing? And as we can see with ribociclib here at the front, there are clearly fewer. So I'm able to prevent more patients from developing metastases. Again, this is an important situation. So what is my conclusion? In other words, a broader group of patients can now receive it based on their risk. all patient groups that have been studied so far in the NATALEE and monarchE studies benefit overall. This means that for patient groups who are eligible, it should be a component of anti-hormone therapy and must no longer be overlooked. I would even go so far as to say that it must no longer be omitted during patient education or in discussions.
So if that's not specifically mentioned, that would be the perfect moment to say, go ahead and challenge your doctor to make absolutely sure you talk about it definitely and that it's carefully considered as an option. That's really amazing. You've just given two more very compelling arguments saying that it works really well in practice and produces excellent results. And also that no matter what the lymph nodes look like, that everyone definitely benefits from it without exception. So the group of people who can benefit has been expanded again, which is quite significant. These are very, very positive and encouraging news. And of course, that immediately brings me to, I'm always interested in the side effects. Are they similar side effects? So abemaciclib and ribociclib, are they actually similar, or more specifically, how do they compare with each other in that regard?
So there is some overlap where they are similar, but they are still different. Now let's start with the differences. We see that about 10% of patients on ribociclib experience elevated liver values. This doesn't cause pain, but it must be measured regularly. And if it occurs and exceeds certain levels, the medication must be stopped. This is less frequent or severe with abemaciclib. Secondly, the gastrointestinal side effects seen with abemaciclib occur significantly less often with ribociclib. However, the reduction in white blood cells known as neutropenia is more pronounced with ribociclib compared to abemaciclib. This means, as with the other study, yes, therapy is necessary, of course, but it also means more frequent visits to the doctor. Or more often, yes, not frequently, and at intervals, just as we discussed with the monarchE study or with the standard use of abemaciclib. At the beginning, with ribociclib, you have to do 2 ECGs, but a couple of years later, you don't even think about it anymore. So it's really nothing serious.
Why do people not think about it anymore after 2 or 3 years?
Well, if you try to remember whether you had to go to the doctor again just for an ECG, that's what I mean.
See. I thought that after 2 or 3 years, you just wouldn't do it anymore.
No,
now, of course,
you
that
keep
makes
doing
sense.
that, but I would say, for me personally, those really aren't reasons not to start a therapy.
Yes, great. Then I would say let's move on to the last area of study, hormone receptor positive. Let's continue directly.
And there's a really important study on this, so to speak. We've already received some initial data, and of course, many people have said, well, if we observe this over a longer period, is it still safe? What is our personal feeling about it? That's how it is for both doctors and patients. In all of this, that means I have hormone-dependent breast cancer and then I become pregnant, or I want to become pregnant. These are, so to speak, the absolutely crucial questions, especially for young women. And that's where the positive study comes in. That means, in this case, young women with a desire to have children were specifically observed as part of a large study where ovarian function suppression was also examined, the SOFT and TEX studies in this context. And then they looked at the women and said, well, every patient thinks if I get pregnant, I'll have a lot of hormones. Does that awaken tumor cells, dormant tumor cells, or whatever else is said? For example, if I also have the initiation of a pregnancy, which can sometimes be supported by medication, does that trigger anything, so to speak, in all of this? These are very important questions. If I stop my anti-hormone therapy in order to become pregnant, does that have an impact, so to speak, on my survival? These are the most pressing questions we face every day in the clinic in this situation. And that's what this study investigated. That means they didn't randomize the women, like she gets pregnant or not. Of course, that's not ethically possible. Yes, of course. Instead, they simply analyzed what happened to the women who became pregnant, how things turned out in order to provide medical data, so to speak, and to offer more certainty during consultations. That is ultimately the goal of such a registry study. And in this case, they included over 500 women and looked at the median follow-up for well over 5 years. So for us, these are important, crucial data with adequate follow-up in this situation. Endpoints, you've basically already covered all of this. Again, survival is what is examined. In oncology, survival is essentially the decisive factor, of course. So now you first look at the fact that many became pregnant, 75%. That's already a positive message. There were also many who had undergone chemotherapy and so on among them. Then many patients also He gave birth to a perfectly healthy child throughout all of this. And many of them, after their maternity leave, resumed anti-hormone therapy. So now let's take a look at whether it is actually safe for, let's say, our young families or women who say, I want to fulfill my desire to have children in all of this. The first question here, so to speak, is something you can read up on again. For example, how many twins were born and so on. Of course, not all of these are spontaneous twin pregnancies. We know all of this from reproductive medicine. In some cases, 2 eggs may have been implanted, and so on. These are various countries that have been analyzed together in all of this. So, and if you look at birth defects, for example, you also don't see a higher rate of them. The question in all of this is, I took something, I had chemotherapy, so took tamoxifen for a few years, so to speak. How does that affect things? And you were supposed to, or ideally should, wait about 3 months after stopping tamoxifen before becoming pregnant. The FDA actually recommends waiting a bit longer, basically waiting through the whole summer, but that's roughly the time frame. And this is the most important curve. There is no difference between those who did not want to become pregnant or did not get pregnant, that is, who continued taking their medication, and those who stopped, became pregnant, and in most cases resumed their medication afterwards. So it is possible to become pregnant. What I think is important for the outpatient clinic, there is no reason not to pursue the desire to have children, period. I think that's a very important message.
Beautiful. I just think it's really, truly wonderful.
Yes, before it was always more of a gut feeling or something like that. Now, when you have the study data for yourself, it also gives us as therapists the confidence to proactively tell patients that they do not have a higher risk in this situation. When the question is about wanting to have children, generally speaking, there is really no need to advise against it for most people.
Yes, I think it's really a lot about the factor of fear, that you're afraid, if I don't do something, will it be my fault if my cancer comes back? All of these fears, all of these overwhelming emotions, everything that comes crashing down on you. And of course, it's also a bit of an ethical issue. Why would you want to have a child just so you can stay alive? And I think this data, this support for every woman who wishes to have a child and didn't choose for breast cancer to get in the way, that there is an option. Not just that there is an option, but also that by doing so, she isn't putting herself in danger or later thinking, oh God, did I really have to have a child no matter what? Now the cancer is back. No, that's nonsense. Now you can look at the numbers in black and white and say, no, look here, this is absolutely okay. You're not taking any risk. Of course, you still are, after all. When you take the pill and say, I'm doing this anti-hormone therapy, and it's always said that it's kind of your safety net. Would you want to give that up voluntarily? No, of course not. That's why I really welcome the results of this study. And I hope that a lot of people go on to have lots of children after their breast cancer therapy, because let's be honest, most young women, they don't choose this situation. They had planned their lives differently and are usually still hoping to have children. And then comes the diagnosis, and suddenly it's all about, well, what about having children? And there's just so much coming at you. And then I just think it's wonderful to be able to say that in the end, there's a lot of hope.
Now, compared to the general population, because you have cancer, the risk of recurrence is still there when we look at the numbers, 11 and 14%, but it is not increased by pregnancy. And that's the important message. And that's exactly what we hear every day, just as you described. Or also women who already have a child and are told, well, be glad you have a child or something like that. But they say, I always wanted to have more with my husband, if you think about it. According to the data, there is no reason not to fulfill the desire to have children. Period.
But I also think it's about self-determination. A cancer diagnosis inevitably comes with a significant and overwhelming loss of control. But you can still regain some sense of self-determination and say, it wasn't cancer that decided for me that I can't have children anymore, but I can still have an active say in it. I think that's wonderful.
Yes, so that's why we also looked up the study with your team and said, I think this is a really important message that we're bringing back from ESMO.
And now to wrap up the topic of hormone receptor positive cancer, or our video of it, this would be our final study that we're presenting here as part of this presentation. You get to do the summary again.
So once again, pregnancy does not change the prognosis regarding breast cancer. So if the desire is there, There is no reason not to fulfill it. Period.
Wonderful. I'll just leave it at that. With that, I want to thank you all very, very much for taking the time to go through the studies from ESMO on hormone receptor positive cancer with us in such thoughtful detail. I truly appreciate your insights, and I also want to thank you again for that. I'm looking forward to our next recording together. Thank you very much.